Welcome to Cancer Buzz, a resource of the Association of Cancer Care Centers. This show is developed for cancer care professionals to give you fresh takes on the latest in oncology. Today, we continue our series about optimizing the role of the Oncology Advanced Practice Provider. APPs are not just clinical mainstays. They drive innovation and are stepping into leadership roles that advocate for better understanding and use of their skills to solve a number of challenges facing oncology care centers today. We have a revealing and vulnerable conversation today with three leaders to tell us how they're advocating to elevate the value of APPs. Jessica Leibelt is a nurse practitioner at the Fred Hutchinson Cancer Center in Seattle. Jessica, you manage a team of oncology site APPs, and you're advocating for their best use. What does that look like?
Especially in my particular role, my team in community oncology, we see all diagnoses. We're not subspecialized, and we have infusion clinics embedded. And so being able to just say, oh, this is how they've been utilized and their percentages on paper, and these metrics that come up that we can pull. And then this is how many patients that they've seen. That's not really an accurate measure of how busy we are and how much task switching there is and how much little in between things that you can't really see, all the nurses that come to us and ask us questions, you're not billing for that. There's just a lot of more nuance that goes into, I think, what our work looks like and what it feels like. So I think at the end of the day, always advocating for structures that make their work visible.
How do you push for that visibility and career progression within a large organization?
Well, I think some of that comes down to really just doing some role delineation too within the organization, which we've definitely been a lot better at, especially in our kind of organizational changes and restructuring. So kind of looking at what is the top of scope for APPs, what is the top of scope for RNs, what is the top of scope for MDs, where do we overlap and where can we really shine where the things don't overlap, right? Especially in oncology, I think we do have a huge role in educating and doing symptom management, but also really creative things like doing APP-led clinics, things that are subspecialized, such as in survivorship type clinics and things. Whether that's for example, I do a lot of sexual health and survivorship, and there's other APPs in our organization who've done things like that too, with advanced care planning specifically, or in our ACE clinic, which is acute care.
I would imagine in a lot of other areas too.
So there's a lot of places where APPs can be leaders clinically, and seeing where that makes the most sense for the role. Obviously, in oncology, we've got our oncologists that do the treatment planning and ordering all of the chemo and that kind of stuff. So we know that's where they shine. That's where they do their best work. And then we come in, usually mostly in return visits, but we are involved in some of the new patient visits, which I think is nice to get, an introduction with them. But moving forward, after the doctors kind of get the treatment plan going and get everything organized, we kind of really help carry them, through the trajectory and do their side effect management of their treatment, their education, and kind of filling in some gaps that are always in between all of the different roles. So I think making sure that we're all clear on what we're best at and where we can be the most productive at the top of our scope.
What does that conversation sound like with administrators when you're talking about using APPs to the top of their scope?
Yeah, I think there's a lot of education that goes along with that. And there's a lot of change management that goes along with that too, because I think that a lot of teams, even within the same organization, operate differently. Even if you have, let's just say, the breast oncology clinic and then the GU oncology clinic, although our roles are technically the same, people operate a little bit differently, right? And so how do we standardize that with some wiggle room? There is sometimes getting physicians on board with letting APPs do more And there's also that balance with having the oncologist be able to trust the APP, which takes time. But also, I think there's a place in there for mentorship, right? And how can we help these APPs grow, especially newer ones, in these roles with these particular teams? And that's not to say that it's physician centric. It's to say that together, how do we get physician buy-in for APPs to take on, more of these things within reason, because we want the patients to still see their doctors. But what is it that you feel most comfortable with us taking over? And then kind of just keep stepwising approach from there once they gain trust. And then they'll see that we're actually really strong partners.
Like many in the ever-changing world of oncology care, APPs need ongoing support in their roles. Carlin Callaway is the lead advanced practice provider of medical oncology at the University of Colorado Cancer Center. She also teaches at the School of Medicine there. Dr. Callaway, thank you so much for coming on Cancer Buzz to share your experiences. When we're talking about driving systemic change and making a new pathway for the next generation of APPs, how do you build a mentorship structure?
So in ambulatory oncology, we have been able to actually refine our process, if you will. People are credentialed in 3 ways with our system. So that includes hospital credentialing, billing credentialing, and research credentialing. And so each of those 3 aspects is tailored to the individual. So somebody who just graduated may need, more time to learn about research, to feel comfortable starting to see patients independently in clinic. And then we also make sure that people are supported as they learn how to cover infusion. And so pairing them up with a buddy, making sure they know who, will answer their questions, making sure we provide them with resources and the ability for people to speak up.
What are some of the common concerns you may hear from early career APPs? And then what do you do with those concerns?
So oncology is very much a team sport. I think it's important for people to know that the questions are always open book, if you will. You may always find a physician, a pharmacist, a nurse, a consultant to help you decide the best way to care for people with complex medical conditions. So I think just giving people the ability to take a deep breath, think through things, and then run their plan by people helps them feel supported.
Why should someone get involved in mentorship?
It takes a heck of a lot of work to hire people, and it takes even more work to let somebody go when it's not a good fit. So much of what I do is trying to help find people who will be a good fit for the organization and making sure that they see themselves within the organization and the clinic space. And so, I'm just grateful for people who are passionate and committed to lifelong learning and willing to do the right thing to help people. I think we can truly teach concepts and trials and drugs and results, but I think finding the right person is so important. And that's sort of fueled my fire for making sure that we get it right on all different levels.
The oncology community has changed quite a bit in 30 years. How have you witnessed the evolution of mentorship?
I think it's important to mention that there are formal mentors and informal mentors. And so you may find official programs, in your organization partnering you or offering to partner you with a mentor. You may find them in professional societies as well, or you could just walk down the hallway or connect via Zoom and ask somebody for advice with your promotion packet or advice for how to improve some sort of quality improvement initiative or how to, guide a research study. So I think it's important to know that organizations provide opportunities, but individuals should also be willing, able, and, I don't want to say eager, but they should seek their own mentors as well.
Finally, we turn to a broader landscape and Rachel Stevenson, a physician assistant at ECU Health in Greenville, North Carolina. Rachel recently made the move from Pennsylvania, where she worked with the American Academy of Physician Associates program at the Pennsylvania State Oncology and Hematology Society. Rachel, before we started recording, you were telling me that when you moved, you experienced a marked difference in how APPs are being used in Pennsylvania and North Carolina.
Correct. It seemed odd to me, actually, because APPs were made for the rural setting and to advance healthcare to places that might not otherwise get good, healthcare. And yet the presence of the APP here was less so than in Pittsburgh, in the surrounding areas where I lived, which we were such an integral part of the provider team. Here, it's kind of like they didn't really know what to do with us, so to speak. And I found that there is a big difference in comfort level in some of the APPs versus others. When I started working, I've always been allowed to work, like I said, at the top of my practice. If the state allowed it, you could do it. And when I came here, I couldn't even prescribe letrozole, which is just an anti-hormonal agent for breast cancer. Whereas where I came from, I was writing orders for dose-adjusted R-EPOC. I mean, that's a huge discrepancy in what I was allowed to do and not allowed to do.
How do you think that policy and regulation shapes the ability of APPs to practice at the top of their license, like you're talking about?
I've only worked in 2 states, and I think actually North Carolina has great laws in place allowing APPs to work at the top of their scope of practice. And at some of the more outlying here at UNC, and I think even at Duke, the APPs are allowed to sign for chemotherapy orders and have a little bit more independence in what they can and can't do. So it's not really at a state level where the issue lies. I think the North Carolina Association has done a wonderful job, especially with the passage of the new bill that allows for experienced PAs not to have a supervising physician in a team setting. So that's been a major advancement. And they also joined the PA Compact license, which allows you to get privileges in other states without actually having to apply for a new license, although you would be binded by the laws of the state and not that you're going to practice in and not the state where you currently hold the license.
You've had a wide range of experiences. What do you think is the biggest hurdle to making sure APPs are accepted and used so we can really improve our patient care, especially as the number of patients in our programs continues to grow?
I think we're making our way here. If you haven't had the opportunity to work with APPs, I think that doctors should really try and embrace what we have to offer and not look at us as a replacement, because we can't replace doctors. We aren't your replacement, but we are able to help you and take care of patients because our main goal is the same, is to make sure there is excellent health care for all individuals that come to our door. So as long as we can work together, I think we can provide great health care. Don't focus on trying to hinder anybody, but bring everybody to the best elevation that they can be at, is kind of where I'm at.
We want to thank our guests today. If you like what you hear, and we certainly hope you do, please make sure to tap the follow button in your favorite podcast app so you'll have our latest episodes as soon as they're available. You'll find many topics like this about issues in oncology care, like career advancements, new treatments, and patient care, all on the Cancer Buzz channel. This episode is part of the Optimizing the Role of the APP in Oncology Care program, made possible through the support from the Colorado Oncology Society, Iowa Oncology Society, Empire State Hematology and Oncology Society, Nevada Oncology Society, North Carolina Oncology Association, and Washington State Medical Oncology Society. Until next time, for the Cancer Buzz team, this is Summer Johnson.